भी बड़ा अच्छा है।
मैं खुद आके मुझे अभी बात करें।
सर स्टार्ट
होगी या लोड?
चलो
सर चल मैं ठीक।
Bismillahirrahmanirrahim. On behalf of Pakistan Academy of Family Physicians, I welcome all the participants in this hot summer season. We are thankful to you that you have taken the time out and taken the trouble to come here. Today, as usual, we choose common topics, and we have started series of dermatology lectures with Messrs. GSK Stiefel, and this is the second lecture of the series. Last time we had a presentation on dry skin. This is the second lecture, and next month I think it will be on 12th. Next month that will be on fungal infections. Today we are discussing acne, a very common problem, and before I start I request the Professor Saab, I will request Dr. Abdul Rauf Saab to please recite a few verses from Holy Quran.
قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Jazak. Thank you. So I'll request Professor Tariq Rashid, who is Professor of Dermatology at Fatima Jana Medical College and Gangaram Hospital. So he will enlighten us on the management, especially of acne.
Thank you. Thank you very much for giving me this opportunity to talk about a very common problem, and it is Acne Vulgaris. Next. Acne Vulgaris is one of the very common skin disease which affects almost 85 to 100% of people at some time during their lives. Next. Now, Acne Vulgaris is basically a chronic inflammatory disorder of pilosebaceous unit. So first, let us discuss what is pilosebaceous unit. And this is the opening of the follicle on the epidermis, and this is the hair follicle in which the hair shaft lies. And this is the sebaceous glands which opens through sebaceous duct into the pilar canal. So basically, Acne Vulgaris is a problem of this unit, and this whole unit is known pilo, that is hair, and sebaceous gland unit. So this is the basic site which is involved in Acne Vulgaris. Next. So this is a chronic inflammatory disease of pilosebaceous follicle, and it has two types of lesions. One is non-inflammatory. When we say non-inflammatory, means in which there is no redness, no pustulation, no crusting, and these are two types. And then there are inflammatory lesions where we see redness or pustulation or nodules and cysts. This affects areas of skin with dense population of sebaceous glands, which are the face, upper chest, and back. So these are the major sites which are affected in acne vulgaris. It usually starts during adolescence. It usually starts at puberty, and just it will start at the age of even 10 to 11 years of age. Usually it starts at the age of 12 years, then it may persist up to 35 years of age, but most commonly it resolves in 25 years, 26 years. Face is the predominant site which is affected, then is the back, and then is the chest. The age of onset, it may be seen even in the neonates, which is known as neonatal acne, because the maternal androgens will stimulate the sebaceous glands, and therefore even the neonates can present with acne which is just self-resolving. And it may persist even into the age of 40 to 50 years. because sebaceous gland activity basically declines after 50 to 60 years of age. Next. Just a bit about pathogenesis, because understanding the pathogenesis will help us to understand better risk management. If we know what are the various etiological factors, then it will be very easy to target these factors. Otherwise, it is not possible to understand the logic of the treatment of acne. One is abnormal ductal hyperproliferation. As you have seen, the pylori canal, which is lined by stratified squamous epithelium. So this is the site which is affected initially, and there is the ductal lining, which is lined by stratified squamous epithelium, shows abnormal proliferation. And the most superficial layer, that is the stratum corneum, that is the keratin, accumulates. And this then obstructs the duct. And this obstruction ultimately leads to Comedones formation, which is known commonly as blackhead and whiteheads. So one of the main events due to various factors is ductal abnormal proliferation of the lining. And this leads to excessive keratin, which ultimately blocks the duct. So it means that one of the very important strategies in the management of acne would be to suppress this abnormal and excessive proliferation of the pylori canal lining. This is very, very important to understand. Second important factor is excessive sebum production by the sebaceous glands. And third is abnormal colonization of P-acne bacteria, which is increased in number and its activity increase, and this is lying in the, not on the surface, but in the duct of the hair, that is the pylori canal in the sebaceous glands. This is not over the surface. And the fourth important factor is inflammation. Next. Now this is the first recognized event, that is the abnormal ductal proliferation. Exact cause is not known, but maybe androgen hormones. As you know, in the onset of puberty, the androgen hormone, the testosterone, significantly increase, and then this leads to not only excessive production of the sebum, but excessive and abnormal proliferation of the stratified squamous epithelium, which is lined by the hair. Then lipid composition occurs. And this due to abnormal lipid composition with the puberty, which is affected again due to androgens, abnormal composition of cholesterol versus other lipids, fatty acids, and this leads to abnormal proliferation. Then pro-inflammatory mediators are released, especially interleukin-1, which causes excessive proliferation. Next. Now this is the sebaceous gland. This is the pylori canal, and this is the excessive and abnormal keratin plug. As you see, this has totally blocked this duct. So this is very, very important to understand, and this leads to the Comedone formation, which is visible clinically as blackhead and whiteheads. So now as it is blocked, so sebum outflow is blocked, and the process starts. Next. Different hormones and mediators regulate the sebum production and excretion, especially again the androgens. That is why it starts during adolescence and at the onset of puberty. Growth hormone has its effects, and insulin-like growth factors. Then end organ hyper-responsiveness to hormones. Because most of the cases of acne in males and females, if you do the measurements of hormones, this is normal. So it has been seen that there is excessive response, abnormal response of sebaceous glands to the normal circulating hormones to different enzymes. So this is another pathogenesis. Next. And P-acne, basically this is an anaerobic organism. And this promotes inflammation through various means like inflammatory mediators, interleukin-2, interleukin-8, and tumor necrosis factor. It also promotes inflammation through hypersensitivity reactions to P acne, cell-mediated reaction to P acne. So P acne ultimately leads to more inflammation through various means. Next. So till now we have discussed four important things. That is the factors, main factors which leads to production of the lesions of acne, and one is excessive and abnormal ductal proliferation. And second is the sebaceous gland which is there producing lot of sebum. And third is P acne which is there, and that leads to further promotion of the inflammation. And the fourth is inflammation itself. So if all the strategies should resolve, should focus on these four major pathogenic factors, and then we can easily control the acne. But there are various factors which then influence the acne. Genetic, as you know, it has genetic tendency, but still now exact gene is not located which is regulating this genetic tendency. Some genotyping has been done, but it is, if the parents are affected in the more severe form, siblings are affected, the kids are affected in more severe acne. Then oily cosmetics and hair pomades, oils, as these further occlude the follicular openings, so further blockage. So oily cosmetics should not be used. And various medications, especially steroids, topical and oral steroids, anti-epileptic drugs, most of, I think you have might have seen cases, जो ही ATD start करते हैं साथ ही acne flare up हुए, many cases. So ATD is a very important cause of creation or production of the lesions of acne through all these different mechanisms. Then iodides and bromides. So clinically relevant is ATT. If you start ATT to a patient with tuberculosis, you can get acne. So you should have an understanding that this is due to ATT. You just treat the acne, and as soon as you stop the ATT, the lesion will stop. Another is diet. This is a very controversial basically subject, because most of the patients and the doctors both focus more on the diet, but true scientific evidence is lacking. Scientific proof up till now is lacking. There are conflicting studies. Some studies do correlate something, some dairy items like this, but chocolate and calorie restriction and take lots of fat has no direct relation with that. So we usually don't restrict any diet restriction to patients. Because if you focus on all these four pathogenic factors, where does the diet fit? If it would have any effect, it would be very little. Because some studies do correlate, most of the studies say there is no role, whatever is the scientific data. So you should not, I think we should not pay so much attention on the restriction of the dietary item in patients with acne. Next. Pre-menstrual flare is very common in women. This complaint of 70% women complain of acne flare 2 to 7 days pre-menstrually, and this is due to increased hydration of the duct due to estrogens and progesterones. So what happens with normal estrogens and progesterones? There is ductal hydration leading to blockage. So anything which basically blocks the duct aggravates acne. Next. Sweating again promotes acne again due to blockage of the duct. So any precautions we can advise the patients to avoid all those activities in which there is more sweating during acute flare. Next. Occupation again. Patients in oil industry dealing with petroleum products because of indirect transfer of petroleum products to the face, which is blockage of the duct and acne flare. And catering, there is a lot of sweating, again aggravation of acne. Next. Now there are various endocrine disorders like polycystic ovarian syndrome, congenital adrenal hyperplasia, and other disorders in which there is increased androgens, more resistant, more severe acne. Next. So occlusive cosmetics. So we don't advise the patient not to use any cosmetics. Patient can use water-based cosmetics easily. Main important thing is oil-based cosmetics should be avoided. And Then heat and humidity to be avoided because it blocks the duct. Now excessive and vigorous washing, this is a very patient perception is very wrong in this aspect. They think that acne would improve by vigorous washing. This is a myth. If you do vigorous washing, this basically leads to trauma and leads to further aggravation of inflammation and blockage of the duct. There is no role of more frequent washing because this is not a hygiene problem. As we have seen in the pathogenesis, where lies the hygiene? Nothing. There is not a hygiene problem. This is pathogenesis totally different. A normal washing. Rather, we should use more soft soaps rather than using Dettol or Safeguard, which can lead to irritation of the skin. It's just non-soap cleansers or just mild soap, baby soaps, if you want to. And then the friction and pressure can aggravate acne, again because of mechanical pressure leading to inflammation. The patient should advise not to avoid manipulation of leaves, again due to trauma and inflammation. So if you understand the role of inflammation, many causative factors, the contributing factors can easily be understood. Next. Now just come the clinical features. So till now we have basically concentrated on the pathogenesis of acne, which is very important. That is ductal proliferation, excessive sebum production, P-acne, bacteria, inflammation, all the factors which can lead to aggravation of acne. Ultimately focusing again on these four factors. अभी तक कोई चीज इसमें क्लैरिटी ना हो तो इसको भी बड़ा इम्पोर्टेंट है।
ADD में क्यों?
ADD में pathogenesis are unknown, but most of the time it is said that probably it affects the P-acne bacteria, non-proliferation.
Sweating में
Sweating ना sweating जब होगी ना आपकी स्किन के ऊपर से पीछे तो सारी स्वेट में आपकी जो डक्टल ओपनिंग है ना वो हाइड्रेट हो जाती है, वो क्लूड हो जाती है। तो क्लीन जितने भी स्वेटिंग है ये ऑयली प्रोडक्ट्स है क्लीन ऑफ द ऑस्टियो, इसलिए ऑयली कॉस्मेटिक्स भी अवॉइड करते हैं।
Atmosphere as we have just said, not aggressively wash our face, but in polluted atmosphere like inside the city, liquid washing is not helpful.
No, washing would not help. Because this is not a hygiene problem. The bacteria is not lying on the surface. Problem is this: bacteria is in the canal. If we do the washing, the bacteria which is problematic will not help.
Excessive sweating will be
dangerous. Cold environment is good. Normal washing is required. I don't mean to say patients ऐसे करते हैं कि घंटे बाद wash करते रहते हैं.
सारा दिन करते हैं.
सारा दिन ही करते रहते हैं.
कितनी दफा धोएंगे?
यही जिस तरह नमाज अल्लाह ने दिया हो
4-5 दफा नमाज पढ़े तो साल के साथ थैंक यू सर। Then occasion, why it is common in those countries?
नहीं
वजह तो यही है।
वजह तो नहीं ना, वजह तो डिफरेंट है। ये तो एग्रावेटिंग फैक्टर है। वजह तो बिल्कुल डिफरेंट है ना, हार्मोन्स है वो सारा एग्रावेटिंग।
आपने कहा डाइट का कोई इशू अगर तो कोलेस्ट्रॉल हाई कोलेस्ट्रॉल उससे ये एंड्रोजन और उससे क्या
वही स्टडीज हुई है ना बेशुमार दुनिया में। उन्होंने डाइट का इफेक्ट हार्मोन्स पे देखा है, डाइट का इफेक्ट कंट्रोल स्टडीज हुई है। अल्टीमेटली कंक्लूजन ये है कि डाइट का कोई डायरेक्ट प्रूफ साइंटिफिक नहीं है एक्ने के एग्रीवेशन। कुछ है स्टडीज प्रूव कोरिलेट, लेकिन चॉकलेट जो सबसे ज्यादा उसके तो बहुत सारी स्टडीज है उनका कोई रोल नहीं है। डेयरी प्रोडक्ट्स को थोड़ा बहुत कोरिलेट कर रहे हैं कि मिल्क एंड लाइक दिस एग, लेकिन कंट्रोवर्शियल स्टडी है। जितना हम स्ट्रेस देते हैं ना पेशेंट्स को, जितना पेशेंट समझते हैं सिर्फ वो करते हैं। क्लिनिकल फीचर्स में आपके ये बड़े इंपॉर्टेंट है। नॉन-इन्फ्लेम्ड लीजन्स, ओपन कॉम्बिनोन ब्लैक इसलिए बोलते हैं नजर ब्लैक आती है। अच्छा ये भी बड़ा मिसकंसेप्ट है, ब्लैक इज ड्यू टू द डस्ट एंड डर्ट, इसको रिमूव करते हैं तो बिल्कुल गलत। एंड वाइट कॉम्बिनोन्स जो स्किन कलर नहीं है उसको वाइट कॉम्बिनोन। अब ये उनको क्यों हम ऐसे बोलते हैं देखिए। नेक्स्ट अब ये देखें इस स्टेज पे स्किन के ऊपर आपको कुछ नजर नहीं आएगा। दिस इज नोन एज माइक्रो कॉम्बिनोन, बट इन पेशेंट्स हु आर हैविंग एक्ने, genetic tendency to acne, micro comedones formation is going on. Even if the clinical lesions are settled, micro comedone formation may continue for years. Again, this point is very important to understand. And what is micro comedone? Basically, the abnormal ductal proliferation accumulating the keratin, and so it is not sufficiently blocked. So there is a partial blockage. This is known as microcomedone, which is not visible on the surface. Next. Now this is closed comedone. इसको close कहते क्यों हैं? Close इसलिए कहते हैं कि इसमें जो blockage है, this is at a distance from the opening. This is the follicular opening. This blockage is not extending up to the opening. So this is as a surface. The skin is close, approximated on the ostium. So you can't see directly this blockage plug. Plug is not visible to you. That is why this would be visible as skin-colored papule, firm layer. Clear मेरी बात है? क्योंकि ये नजर नहीं आ रहा ना, थोड़ा नीचे है और स्किन ओपनिंग ऊपर से बंद है, नीचे डायलेशन है, तो वो आपको ऊपरा हुआ तो नजर आएगा लेकिन वो स्किन कलर नजर आएगा. इसको व्हाइट हेड बोलते हैं. अच्छा, दूसरा जो है नेक्स्ट, इसको ओपन कॉमेडोन बोलते हैं और ये ब्लैक कॉमेडोन होता है. अब ये सारा ब्लॉकेज हो गया इवन अप टू द ओपनिंग. दिस इज नो ब्लॉकेज. अब व्हाई इट लुक्स ब्लैक is totally different from what the patient produces. This is basically a combination of fatty acids, keratin, stains of the stratum corneum, and oxidation products because it is exposed to the environment. So all this leads to black color. No relation.
This suffering and that gives black ink.
नहीं. आपके जो fatty acids हैं, उनकी oxidation products, आपकी जो keratin है वो ही कॉम्पोनेंट होती है. आपकी जो डिस्ट्रॉयड बाकी स्पेन है वो बनते हैं, ऊपर से ऑक्सीजन है. So this gives a black color. No dirt in this case. So this is known as black color. Next. So there are different types of comedone. This is microcomedone. इसकी इम्पोर्टेंस ये है, जो आपको दुनिया में रिसर्च हुई है, कि जिन पेशेंट्स को एक्नी है और काफ़ी है, उनको 5-5 साल तक आप रेटिनॉइड लगवाते रहे ताकि माइक्रोकॉमेडोन न करें. प्रॉब्लम इज दिस, रिकरेंस को अगर आपने अरेस्ट करना है, पेशेंट हु आर प्रोन टू एक्ने मस्ट यूज टॉपिकल रेटिनॉइड फॉर 3 to 4 years, even in the absence of acne lesions, because this microcomedone formation is a process which continues for years. This is, ये कौन सा बनेगा?
ये वाइट
वाइट हो,
वाइट है,
ये ब्लैक हो,
ये ब्लैक,
ये ब्लैक हो.
ठीक हो गया.
स्पेशियस ग्लैंड बनेगा.
ये ओपन कॉमेडोन्स हैं जिसमें सीबम केराटिन कॉम्पोनेंट्स अपीयर ब्लैक विद ऑक्सीडेशन प्रोडक्ट्स. नेक्स्ट. अब ये देखें, ये सारे हैं ब्लैक कॉमेडोन विजिबल. नेक्स्ट. These appear white, skin colored. White नहीं नजर आते, skin colored नजर आते. It lies at a distance from follicle. Next. अब ये देखें ना, छोटे-छोटे imperfections. It's not black. This is white heads. और सबसे पहले बच्चों में 10 साल 11 साल की उम्र देखेंगे फोरहेड पे ऐसे यूज होगा, और वो स्टेज को हम इग्नोर कर देते हैं. उसको इग्नोर नहीं करना चाहिए. असल में पॉइंट जब बच्चों के ऐसे नहीं, हम चाहते हैं तो आउटग्रो हो जाएंगे, एज के साथ है, नो प्रॉब्लम. देखिए ना, ये ब्लॉकेज है. ये ब्लॉकेज जब बढ़ेगा तो पीछे से सेबेशियस ग्लैंड रप्चर होकर इन्फ्लेमेशन कर देंगे. तो आपने इस ब्लॉकेज को खत्म करने की जरूरत है. That is why it's very important to start topical retinoids at this stage to arrest the abnormal and excessive proliferation. ये बड़ा इम्पोर्टेंट है. नेक्स्ट. अब ये कंपैरिजन है, ये है ब्लैक हेड्स और ये है व्हाइट हेड्स. नेक्स्ट. अब इसके बाद जो लीजन्स हैं वो इन्फ्लेमेटरी लीजन्स हैं. अगर ये हम चलते रहे, लीजन चलती रहे, ब्लॉकेज परसिस्ट एंड इट लीड्स टू रप्चर ऑफ द सेबेशियस ग्लैंड्स. द फैटी एसिड्स वुड एंटर इनटू द dermis and in the subcutaneous tissues, would start the whole cascade of inflammation, and there would be reddish papules, then which lead to pustules and so on, and nodules. Next. अब ये बनने देखना कॉम्बिनेशन है ब्लैक हेड्स, व्हाइट हेड्स एंड दिस रेडिश papules. This is known as moderate acne. Next. अब ये उससे भी वर्स होती जा रही है. ठीक, तो जो कॉम्बिनेशन है व्हाइट हेड, ब्लैक हेड्स, papules, नॉड्यूल्स वो होती है जिनकी डेप्थ फील हो। आप ऐसे पेट करें और आपको ना नीचे डेप्थ फील हो, दिस इज नॉड्यूल, दिस सिग्निफाइंग द हायर रिस्क ऑफ स्कारिंग। ये सिग्निफिकेंस है, जितने डीप जाएंगे उतनी स्कारिंग ज्यादा होगी। तो पेशेंट शुड नॉट एंटर इनटू द नॉड्यूलर स्टेज ऑफ एक्ने। नेक्स्ट देखिए ना, ये बहुत, ये नॉड्यूल्स
सिस्टिक।
अब ये जब रिजॉल्व होंगे स्कारिंग हो जाए, तो अगर शुरू में इसको कंट्रोल कर लिया जाए देन इट्स मच। नेक्स्ट, इट्स अ वेरी स्वेयर केस। नेक्स्ट, but this is a severe case of inflammatory acne which has poses a lot of risk of scarring. Next, multiple nodules. Next, severe nodule. So when these lesions heal, acne to leave either behind pigmented lesions or scar. Next. Now scarring may be different types. If it is elevated in form, this is known as hypertrophic or keloidal scar. Or it may be depressed and this is known as atrophic scar. Next. This is all atrophic. Next. This is keloidal scar. Next, again keloidal scar. Next, it has to be differentiated from rosacea and detailed folliculitis. दो कॉमन है कि एक्ने है या रोजेशिया। नेक्स्ट, अच्छा रोजेशिया बिल्कुल ऐसे ही नजर आता है जैसे एक्ने है, लेकिन 3-4 इंपॉर्टेंट डिफरेंसेस हैं। रोजेशिया में कॉमेडोन्स नहीं होते, यानी कि व्हाइट हेड और ब्लैक हेड्स अगर नहीं है आप सोचेंगे शायद पेशेंट को या तो डिटेल फॉलिकुलाइटिस है या रोजेशिया। दूसरी इंपॉर्टेंट बात, रेडनेस बहुत होगी, इसीलिए इसको रोजेशिया, रोज लाइक, क्योंकि इसमें ना रेडनेस बहुत आती है, चिन इज रेड और मीडियल एस्पेक्ट्स इन्वॉल्व होते हैं। एक्ने में ज्यादा थोड़े पेरिफेरल चेक्स इन्वॉल्व होते हैं, रोजेशिया में ज्यादा मीडियल एस्पेक्ट्स इन्वॉल्व होते हैं। और पेशेंट को फोटोसेंसिटिविटी होती है, भी इस धूप में जाएगा रेड हो जाएगा।
रोजेशिया में जो इन्फ्लेमेशन है
उसमें ये इम्यून मेडिएटेड प्रॉब्लम है और इसमें भी बहुत सारी पैथोजेनेसिस है। इसमें भी एक्ने इन्वॉल्व नहीं है, ये नॉर्मल वेसोडाइलेटर रिएक्शन है, मे बी ड्यू टू स्पोरम फॉलिकुलाइटिस, मे बी ड्यू टू सम फॉलिकल माइट्स, सो इट्स पैथोजेनेसिस प्रोटीन। नेक्स्ट, इसमें आपको ना बहुत ज्यादा ट्रांजिटेजेस नजर आएंगे। नेक्स्ट, ये समटाइम्स ये फॉलिकुलाइटिस में ये लगता है एक्ने है, लेकिन इसमें भी आपको कॉमेडोन्स नजर नहीं आए। सो फाइंडिंग ऑफ कॉमेडोन्स इज वेरी इंपॉर्टेंट इफ यू वांट टू से दैट दिस पेशेंट इज एक्ने। नेक्स्ट, बेशुमार साइकोलॉजिकल इफेक्ट्स हैं, स्ट्रेस, एम्बैरेसमेंट, एंजाइटी एंड ब्रेक ऑफ कॉन्फिडेंस, सो मेनी, इवन सुसाइडल आइडिएशन इन वेरी सेंसिटिव पेशेंट्स। नेक्स्ट, अब इसकी मेथड। नेक्स्ट, तो जनरल मेडिसिन तो हमने पहले भी मैंने डिस्कस की कि ऑयल बेस्ड कॉस्मेटिक्स को अवॉइड करना है, मैनिपुलेशन को, स्टीरॉइड्स बिल्कुल ना। बैटनोवेट, अच्छा बैटनोवेट डर्मोवेट पेशेंट ज्यादातर आप मिक्स करके लगाते हैं, उससे फिर एक्ने बन जाता है या रोजेशिया भी बन जाता है। स्टीरॉइड से दो कॉम्प्लिकेशन बड़ी सीरियस बनती है, एक्ने बनती है, रोजेशिया, तो दोनों ही मुश्किल पड़ जाता है। फेयरनेस क्रीम्स भी इसलिए ना लगाएं क्योंकि उसमें भी मेजॉरिटी में स्टीरॉइड्स कंपोनेंट्स मौजूद हैं। फेशियल और मसाज क्यों ना करेंगे, आप थोड़ा बता सकते हैं?
इंजरी होती है,
इंजरी हो रही है,
एक्सेसिव इन्फ्लेमेशन,
so no more of facial massage and heat लें और भाप लें, एक्ने में इसका नेक्स्ट। अच्छा ये एक्ने मिथ्स है, एक आप सब नॉट टू वरी, यू विल ग्रो आउट ऑफ इट। और जो ही बच्चों को करने कहते हैं तो नहीं दाने हैं ठीक हो जाएंगे, समझ में निकलते हैं, दिस इज अ मिथ। उसको ट्रीट करना बड़ी इजीली ट्रीट हो जाएगी, उसको आगे बढ़ने ना दें। तो ये जो पहला कंसेप्ट था ना कि छोटे मोटे दाने को छोड़ दो, इतना वैलिड नहीं। एक्ने स्कार्स बिफोर हाइजीन, ये दूसरा मिथ है जिसको मैं कहता हूँ कि ये हाइजीनिक प्रॉब्लम है, पोल्यूशन है, बस और कुछ नहीं। पोल्यूशन से इसका कोई ताल्लुक नहीं। एक्ने स्कार्स समथिंग इन योर डाइट, सारे लोग सिर्फ डाइट पे स्ट्रेस करते हैं, बेशुमार चीजें बंद करा देते हैं, ये खत्म होना चाहिए। ट्रीट एक्ने logically with evidence. Acne people just could cure. Vigorous washing helps, ये गलत बात। एंड ट्रीटमेंट्स डोंट वर्क। पेशेंट को ये जरूर समझाएं कि ये ट्रीटमेंट थोड़ा स्लो